Okay, we'll go ahead and get started. I hope it's not too loud here. So thank you everyone for joining. I'm Leslie Appiah. I'm the Division Chief of Academic Specialists at University of Colorado, Academic Specialist in OBGYN, and I'm also the Medical Director of our Fertility Preservation Program. This is the NASPAG Oncofertility Journal Club. It's a national journal club that we hold quarterly. And typically we have a fellow in Peds Adolescent Gyn or REI present an article. And then we have one of our faculty statisticians go over the stats if they're applicable to help us learn how to be better researchers, how to better analyze the data. And so today with us is Maria Morgan. She's the first year PAG fellow at Sick Kids Hospital, and she is going to present the article. Mary will then weigh in on the statistics, and then we'll have an open discussion. So Maria, I'll let you take it from here.
Great, thank you so much for having me. I'm gonna go ahead and share my screen so that you all can see my PowerPoint. And is everyone able to see that? Okay, great.
Yes.
Awesome. Thank you. So as Dr. Appiah said, my name is Maria Morgan. I'm going to be presenting an article today with the help of Dr. Sammel, who is a professor of biostatistics from Colorado. Okay, so I'd like to begin by acknowledging the land on which Sick Kids operates for thousands of years. It has been the traditional land of the Huron-Wendat and the Petun First Nations, the Seneca, and most recently the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. Sick Kids is committed to working towards new relationships that include First Nations, Inuit, and Métis people, and is grateful for the opportunity to share this land and caring for children and their families. So this is the article we'll be reviewing today. It's ovarian stimulation and oocyte cryopreservation in females and transgender males age 18 or less, which was a systematic review that came out of Australia. So fertility preservation is an important component in treatment of pediatric patients with cancers, rheumatologic diseases, hematologic diseases, gender dysphoria, and genetic conditions which predispose them to premature ovarian failure, as I'm sure many of us know. It's well studied in the adult population, but data and options and therapies to protect or restore fertility are quite limited in the pediatric and adolescent population. And as a result, many clinicians may find it quite challenging to discuss and offer invasive fertility preservation treatments to young people with little data on proven long-term benefits, especially in the setting of how vulnerable these populations can be, you know, in the setting of cancer treatments and such. Historically, ovarian tissue cryopreservation has been considered the standard of care for premenarchal patients or postmenarchal girls with limited time before gonadotoxic treatments. However, this paper points out that there may be some limits to reimplantation, so that method may not be always the best. The possibility of reintroducing malignant cells in patients diagnosed with hematologic cancers means that reimplantation of untreated ovarian tissue may not be considered safe in some cases. They also note that in patients with genetic conditions such as Turner syndrome with increased risk of premature ovarian insufficiency, the pathology can be intrinsic to the ovary, and therefore the accelerated germ cell loss with thawing and ovarian transplantation has led to some uncertainty about the likely success of ovarian tissue reimplantation. Given that many patients will only have this one golden opportunity to preserve their fertility prior to commencing gonadotoxic treatments, it is important that there are offered preservation options that will give them the greatest chance to achieve future parenthood in the way that they might want. So there are some reasons why oocyte cryopreservation may be considered in addition to or preferred to OTC in selected populations. A single stimulation cycle followed by a minimally invasive retrieval compared to a laparoscopy and its associated recovery may make the procedure more acceptable to some patients. So important that we consider what we're offering. So the objective of this study was to evaluate oocyte cryopreservation by means of ovarian stimulation in the pediatric and adolescent population. They also aim to compare diagnosis, age, pubertal or menarchal status, and comment on the success rates, adverse outcomes, and psychological morbidity of going through an ovarian stimulation cycle. They use the preferred reporting items for systematic reviews and meta-analyses guidelines, or the PRISMA guidelines. And a systematic search of the literature was performed for all relevant full text articles in the English language in Medline, Embase, the Cochrane Library, and Google Scholar databases. And all articles published prior to August 2022 were included in this search. The search terms that they used were ovarian stimulation, oocyte cryopreservation, IVF, and fertility preservation. They included any clinical outcomes of oocyte cryopreservations in any patient under the age of 18. So based on title and abstract screening, 663 articles were excluded, leaving 67 full text articles that were assessed for eligibility. 5 they couldn't access for review, and ultimately 62 publications were eligible for review. They looked at the year of publication, the country of study, study objectives, study design, sample size, patient characteristics, intervention, outcome measures, and findings. And 23 studies were ultimately included for this systematic review. And they used 2 independent reviewers for quality assessment of each study. And then any discrepancy between those 2 reviewers were resolved through a discussion rather than a third party. So moving to some of the results, the study countries of origin included the US with 16 studies, the UK with 3, Israel had 2 studies, Sweden and China both had 1. The majority of the study types were case reports, but also included were several case series, retrospective cohort studies, prospective cohort studies, and a letter to the editor. The studies included a total of 468 participants who underwent ovarian stimulation, and the median age was 15.2 years. The range was from age 7 to 18, and there was a total of 488 cycles of oocyte stimulation completed. All but 18 of these cycles, impressively, so that's 96.3%, successfully resulted in mature oocyte cryopreservation. So that's a little bit more of the same. In outcomes according to age, there were 64 participants, as I discussed, that were age range 7 to 18 that were described in one study. There was 3 case reports of ovarian stimulation in premenarchal children, one of whom was prepubertal. The prepubertal child was a 7-year-old with mosaic Turner syndrome who underwent stimulation with a GnRH agonist trigger, which failed to yield oocytes, but then they repeated a second cycle with an HCG trigger alternatively, and this was successful. Excuse me. So this resulted in the retrieval of 6 oocytes, and they were successfully able to cryopreserve all of them. A further 31 patients aged 13 to 15 cryopreserved a median of 9.5 oocytes, and 31 patients aged 16 to 18 cryopreserved a median of 14 oocytes. So comparing patients aged 13 to 17 to patients 18 to 21, notice that younger patients required higher doses of gonadotropins and froze fewer oocytes, so an average of 11 versus 13 for those who are over 18, but this was not a statistically significant difference. Of note, younger cohorts were also more likely I'm sorry. To have cycles, so younger cohorts were more likely to have cycles canceled due to a poor response to stimulation. Included in the diagnoses in the study were cancer, hemoglobinopathies, aplastic anemia, paroxysmal nocturnal hemoglobinuria, gender dysphoria, Turner syndrome, panhypopituitarism, an MDA, autoimmune encephalitis, multiple sclerosis, a dermoid cyst, galactosemia. For Turner syndrome, we saw the lowest yields of mature oocytes, a mean of 3.4 that were preserved. Across all the studies, only 5 patients were not successful in retrieving any oocytes over a total of 17 cycles. And all of these patients had a diagnosis of either Turner's or mosaic Turner syndrome. For cancer patients, a mean of 12.3 mature oocytes were preserved. In sickle cell, a mean of 9, and trans males had the highest yield with a mean of 14.7 mature oocytes preserved. So some form of ovarian testing was performed prior to commencing ovarian stimulation in 19 of the studies that were reviewed. And of the 468 participants, AMH was described in 52, FSH was described in 33, and an antral follicle count was described in 25 participants. The median, as you can see, of AMH was 2.9, the median FSH was 4.5, and the median antral follicle count was about 16. 4 patients were described in one study who had an FSH of less than 1. These patients were aged 14 to 18 years old, and they all had a diagnosis of Turner's or Turner's mosaicism. And they had a median 9.5 oocytes retrieved, and 5 that were actually cryopreserved. One further case report demonstrated an FSH of less than 1 in a transgender male who was on a GnRH agonist for pubertal suppression. And this patient had 5 oocytes retrieved, 4 of which were able to be cryopreserved. And then there was only one patient who had an FSH greater than 20. This was a 14-year-old with Turner's and had an AMH as well of 0.03, and no oocytes were retrieved over 3 cycles for this particular patient. So by looking at kind of more at the AMH and antral follicle count, 11 patients of varying ages with diagnoses, including being a transgender male, having cancer or Turner's, had an AMH that was less than 1.1. However, the median number of oocytes retrieved amongst these patients was 12.8 and 8.7 cryopreserved. So even despite these very low AMH values, they were still able to stimulate and cryopreserve quite a few eggs for most of these kids. 4 patients aged 7 to 15 with either Turner's or Turner's mosaicism had an antral follicle count of less than 7, indicating low functional ovarian reserve. But they also had a mean number of 9.2 oocytes retrieved and 5.2 cryopreserved over 5 cycles. So again, lower numbers for ovarian reserve, but still resulting in some successful cryopreservation. And then a low antral follicle count was observed in one 14-year-old with leukemia. However, 21 oocytes were retrieved and 10 were cryopreserved over 1 ovarian stimulation cycle for that child. So all of the protocols, except those described in 5 studies, were random star antagonist cycles that use recombinant FSH with or without human menopausal gonadotropin for ovarian stimulation. And one study described, as we talked about a little bit earlier, the failure of a GnRHA trigger to produce oocytes in a prepubertal child, but then they were subsequently successful with an HCG trigger in a second cycle. Only one study of this whole review reported a pregnancy resulting in a live birth after long-term cryopreservation of oocytes, and this was a 17-year-old female who was requiring gonadotoxic treatment for pulmonary hypertension. The oocytes were warmed after 5 years of storage, and 2 embryos were transferred into a surrogate due to the maternal medical condition. She could not carry herself, and it resulted in a healthy baby boy delivered at term. No other patients have been reported to have utilized their frozen oocytes to create a pregnancy, though this doesn't mean it wasn't necessarily done. It's also unclear the years from which all of these studies were published. They state that they collect the data, but it wasn't published in the study. So the question remains if perhaps we are too early and some of these patients may just not be ready to pursue parenthood at this time. Successful mature oocyte cryopreservation was achieved in all but 18 of these cycles, so 96.3% were successful. And then an additional 53 cycles were canceled for a poor response. However, the cancellation rates should be kind of interpreted with caution due to the retrospective nature of the studies. This systematic review therefore demonstrates that ovarian stimulation and oocyte cryopreservation is achievable in the young, although numbers still remain small and the long-term outcomes of the stimulation is really unknown. Until recently, this has only been described in post-pubertal patients, but there was a couple who were pre-menarchal and one that was pre-pubertal that were described in this study. So this does challenge the traditional thinking that oocyte collection can only be considered in those who are physically and emotionally mature, but questions around the number and quality of these oocytes still remain somewhat unanswered. Regardless of diagnosis, there's a total paucity of data regarding utility and pregnancy outcomes from oocyte cryopreservation in young patients. And there is evidence that prepubertal ovaries contain significant numbers of follicles with abnormal morphology that seems to be lost at some point during adolescence. Of note, 3 studies broadly comparing the adolescent population with the adult population reassuringly displayed that there was no significant difference in the number of oocytes cryopreserved between different age cohorts, but outside of the larger cohort of studies in this review, there was a trend to higher numbers of cryopreserved oocytes in the older age ranges. Higher rates of fetal aneuploidy has also been described in adolescent pregnancies when compared with women in their 20s. So therefore, the future ability to obtain a viable pregnancy and a live birth is still somewhat uncertain, especially in the prepubertal cohort. Only a single case report, as we discussed, of that 17-year-old was described in this literature. Interestingly, the use of standard markers of ovarian reserve, such as AMH and antral follicle count in predicting response to ovarian stimulation still kind of remains unclear. There's a discrepancy between unfavorable test results of ovarian reserve and the associated number of oocytes cryopreserved in some case studies that are noted in this review, which may show that in this population, these markers of ovarian reserve are less dependable in predicting response to stimulation. And then until recently, ovarian stimulation has only really been described in post-pubertal patients. And there was only one in this study who was prepubertal and successful in cryopreserving some oocytes. So, future directions. As we continue to consider ovarian stimulation in pediatric and adolescent patients, some more questions continue to arise. For young people who undergo stimulation, we should continue to follow to evaluate what effect, if any, there is on an immature HPO axis. As the transvaginal approach is often considered unacceptable in a young cohort, transabdominal ultrasound of the ovaries was frequently utilized in monitoring in the studies that were included in this review. And one study even had a successful transabdominal oocyte retrieval in a prepubertal girl. The transabdominal approach of monitoring retrieval is much more technically difficult, especially in those who are not comfortable or have not been trained in it. So there's an important area of future research to assess the level of accuracy when monitoring ovarian reserve and successfully retrieving oocytes through a transabdominal approach. We also want to continue to consider the psychological impact that retrieval may have on a younger population, as well as the dysphoria it potentially can trigger in a trans population. So the descriptions of ovarian reserve markers, as well as baseline patient characteristics, including BMI, Tanner stage, menstrual history, were described in varying detail and often lacking amongst the studies. As I mentioned before, we also didn't know the years of publications of all of the individual studies, so this would really help with the interpretation of these results to know if we're not successfully getting viable pregnancies because of these eggs are no good, or because they haven't been used yet. In conclusion, ovarian stimulation and oocyte cryopreservation is a novel procedure in the pediatric and adolescent population. While it's considered standard practice in adults, long-term outcomes are largely unknown in the young, and therefore we should still be considering this kind of experimental, especially in prepubertal and premenarchal patients. Okay, and I will hand over the mic to Mary.
Hi, everybody. So this was primarily a descriptive study. It really was a good example of how to do a systematic review in terms of the methodology they used. They also pre-designed their data collection instruments just so that they would make sure that they were doing it in an unbiased way. They had 2 reviewers for each paper, and so that's good quality control, I would say. The one thing I did notice is that they really did not describe the methods for combining the information. So they gave median oocyte counts, and a lot of the individual studies had median oocyte counts, but it's not clear how you get an overall median from multiple studies, given that the sample size is different for every study. So the median of medians is not necessarily accurate, right? But if they did report means of means usually gets you to the overall population mean. And so even in a descriptive study, you have to think about how do you aggregate data when you have grouped data as a consideration for the future. And then Maria and I had a couple of good conversations about this paper. And so I look forward to hearing what you guys think about this as well. As sort of, I want to just encourage you to say, what can we say as a result from this paper, but also what's missing? What is it we cannot say with respect to what we're learning from this meta-analysis? So let's open up the...
Yes. Yep, let's open up the discussion. Thank you both. Thank you, Mary, and thank you, Maria, for presenting that so clearly and so well. So I think one thing I'd like to hear are individuals' experiences at their institutions with stimulating oocytes. This paper came to be because we had some discussions across institutions about who's doing what in terms of our younger populations, and should we all be striving to stimulate oocytes in this younger population? So I'd love to hear what individuals are doing. I'll tee up our team and as our REI fellows, Dana and Simone, if you want to comment on kind of what we're doing here, and then we'll see what others are doing.
Hi, can you guys hear me?
Yeah, Appiah, can you hear me okay?
Oh, wait, my
Yes, we can hear you now.
my thing is backwards. Yeah, we, as far as I know, we haven't done ovarian stem on patients who haven't reached menarche yet. I think the youngest we've done is, I want to say 12 here. But then I don't know if you have any comments about, we usually do, if they haven't reached menarche, then we usually recommend ovarian tissue cryopreservation. But yeah, I don't know, Dana, if you have any comments.
Simone, was the 12-year-old the one with Turner mosaicism or Turner syndrome that wasn't successful with the cancel cycle, or was it that a different patient?
It was a different patient. It was before I got here. We just had someone, well, we did have a patient who with Turner's mosaicism. She was 18 years old. And she was pretty successful. She's gonna undergo another cycle eventually, but I think we got like 16 eggs or something. And she was like 76% Turner's mosaic. But as far as, we just also had another patient with like 2 Turners, but her FSH was very high. I think it was like 100, something crazy. And we didn't get anything from her. Okay. I think she was 19.
Gotcha. Dana, is that your understanding as well?
Yeah. Sorry, my internet just cut off for a second, but yeah, she was the one who had an undetectable AMH and her AFC was like 2 to 3. And
Mhm.
she had been diagnosed with POI at age 15. And despite the kind of poor prognosis,
Oh.
still
Okay.
attempted to do ovarian stimulation. And I believe, Simone, correct me if I'm wrong, but I believe that she was like cycle day 18 of stim and had an estrogen of like 20 or maybe like not even that high. And like
Yeah.
no detectable, no like measurable follicles. And so decided to cancel. And so we were going to kind of look into, does the fact that she stopped like menstruating several years ago, does that portend a poor diagnosis? And should we really be trying to simulate these Turner syndrome patients prior to like what's kind of the time frame from amenorrhea to stimulation that might still have some success? So yeah,
Can I ask a
I'm
question?
on mute. Thank you both. Yeah, let's open it up.
So I think there's a question that we in Toronto, we've just kind of restarted our fertility preservation program within the last year. And a question that we've been struggling a little bit with is who we're offering which procedure to. So like who are we offering our ovarian tissue cryopreservation to versus a cycled stimulation? Like, of course, we know if there's limited time, then that sometimes, means that we don't have time to stimulate them and we just go right to the laparoscopy. But how do you guys kind of differentiate that, your various programs?
It's a great question. Hey, it's Glenn Chapman here from Cornell. I think some of our fellows are on. They made it somewhere in the operating room. I apologize. This is really a great forum, and I want to thank Leslie for sending me the invitation and for inviting us. I think it's really important to determine in the specific patient what the situation is. Let's say, for example, a Turner syndrome patient who you know is going to have a rapid decline in ovarian reserve. Even if you take out the ovary to prevent that decline, when you put it back, we don't know, but we assume you're going to have the same decline in ovarian reserve in the return tissue. So it depends really on what the situation is, what's going to happen. If someone's going through chemotherapy tomorrow, they don't have a choice. You can't really freeze eggs. So it depends on the situation. Our Turner's patients, what we do with them is we watch their AMH. Usually they're menopausal before they even get to the point of having their first period. But if you can watch their AMH and see what the decline in AMH level is over time, you can try and catch it at the earliest age possible to try and freeze their eggs then. So it really depends on each individual situation that has to be assessed for what their egg reserve is currently and what their predicted reserve is going to be in 6 months, a year, 2 years, to determine at which stage you have to do it. This population, it's very, as everyone knows on the call, 12-year-olds, convincing them to go through blood tests and stimulations and an egg retrieval is not easy. So you have to sort of, figure out when the best time is for that individual person to go through.
Right, I want to echo that. So, right, if patients are pubertal, if a Turner mosaic or Turner syndrome patient is pubertal, and they have time because they're not receiving treatment, then we would obviously offer oocyte cryopreservation. We also monitor our patients. Our endocrine colleagues send the patients to us very early. So we'll monitor their AMH with the goal of trying to get them to puberty. And if they go into spontaneous puberty, then obviously encourage them to freeze eggs. And we're prepping them for that conversation so that the patient is aware and ready. And some 12-year-olds are mature and some aren't, right? So to Glenn's point, it's very individual. And if we can get them to a spontaneous puberty, then we will send them to our colleagues to have a discussion. If we see that they're trending downward and they're going to lose their ovarian reserve before reaching puberty, then we will do an oophorectomy. We'll send them over to the NIH, to Veronica Gomez Lobo's group. They will take out the ovary and freeze it with the understanding, like Glenn stated, that we likely are not going to transplant this back, and we're going to cross our fingers and pray for in vitro maturation and determine if there's any possibility there. I think ideally when we're processing the tissue in those patients, if there are oocytes that are aborted into the media, then potentially we can try to mature those and do kind of a 2-for-1, but that's how we're managing this population.
Mhm.
Interesting. So overall, you guys feel comfortable with the quality of eggs coming out of adolescents versus older patients?
That was the question I put in the chat there for Leslie. So
Yeah, yeah. And this is my thought. So
Mhm.
if a patient is going to lose their fertility, then aren't we better getting as many eggs as we can? And for the ones that are aneuploid, then obviously we can't use those. And the ones that aren't, we can take. I think to not stimulate and not retrieve oocytes because there is a higher risk, I think does a disservice to the patient, right? Because there may be some follicles or oocytes that are okay. And so I don't see the utility in allowing someone to undergo a POI or enter POI because there's a risk and a higher incidence of aneuploidy. Am I thinking of that poorly? It's not a one and done. It's not as if they try now, if they have reserve in the future, then we can certainly try again. But to lose the window of opportunity, to me, just doesn't make the most sense.
yeah, listen, 100%. You've got, for your cancer patients, you've got one shot, and whatever eggs you get, you get. I mean, you get what you get. You don't get upset. I mean, that's sort of what I tell my kids all the time. In the Turner's patients, you don't have really a time limitation. So the question that I put in the chat was, I mean, at what point do you say, okay, you have enough eggs, you don't need to do any more stimulations? If you get 8 or 10 eggs in a cycle from a 16-year-old, we know those eggs are not as good as if you're 26. We can't quote the 8 to 10% success rate per egg frozen. It's much lower than that. So how many eggs do you need? How many cycles do you need? Really depends on, I think, in our experience, the patient's emotional status, how many times they're willing to go through it. Sometimes they'll do 1 or 2 cycles. They'll say, I'm done, whatever I get, I'm not doing it again because I have school, I have, all kinds of things that I've got to go through. And some will keep going 5, 6, 7 cycles to get, 20 or 30 or 40 eggs. There's no right answer, I think.
We have one of our ovarian biologists on, Josh, who does a lot of modeling. Josh, I don't know if you wanted to comment. I know you joined late, so you may not have been able to hear the full article, but essentially it's on oocyte stimulation in adolescents and looking at that younger adolescent group versus that older adolescent group. There was a success rate of 93% in terms of successful retrieval of oocytes. The question is, what is the fidelity of those oocytes in the future? And so I don't know if you have any thoughts on this as you're in this space a lot.
Well, thanks, Leslie. And I was just finishing something that I just put in the chat because what I did join in time to hear is that AMH levels are, not necessarily directly related to the remaining reserve in these patients. And I hope we can get back to that question because I'd love to know. But, I can sort of default to lessons from rodent models and egg quality in prepubertal animals like mice, and those eggs are also terrible. However, so many are produced in a given stimulated cycle that you can usually get quite a lot that are useful. So my guess, and this isn't an answer to why the quality is bad, but that is some subset of oocytes retrieved will be usable in the future. And it's just a matter of, that cohort at that time tend to be of poor quality, and that's measured indirectly, and very rarely directly. I didn't catch in that review whether any patient has gone on to age up and then do fertilization and achieve pregnancy. I don't know that to be true for prepubertal population.
For the prepubertal, no. Yeah, there was a 7-year-old who was stimulated that retrieved 6 oocytes and they were able to freeze them, but we don't know yet there, the quality in terms of fertilization. And the one live birth in the adolescent that they reported was a 17-year-old, so she was older.
Thank you.
So in my conversations with our REI team about the ovarian reserve not being predictive is more so that, and this was a conversation about older adolescents, young adult women. So for example, we would have patients who were cancer survivors who came in and had diminished ovarian reserve, and they were younger, and their ovarian reserve, we're talking like an AMH of 0.02, and I thought, well, this is a done deal. We're never going to get anything. But their argument is that they are younger, so the quality is better at that age. So even though the AMH is low, you do retrieve a better quality egg, which has a higher likelihood of successful fertilization. So we should be setting them for an antral follicle count and then let them consider the options to stimulate and retrieve. And so, Glenn, I don't know what your thoughts are on that.
Yeah, so, it's interesting, the ovarian tissue freezing, there is a prepubertal patient who has a pregnancy from ovarian tissue that was frozen in the past. So we know it's possible for ovarian tissue. And as Leslie said, I don't think we have any data on prepubertal oocytes, because I don't know of any case reports or any outcomes based on that. I'm sorry, Leslie, the question again, I got off topic.
Yeah, the ovarian reserve doesn't equate to lack of ability to retrieve eggs. Yeah,
so I think the one thing is a diminished ovarian reserve in a normal patient never having had chemotherapy. So the 26-year-old that comes in with diminished ovarian reserve, I would agree that her egg quality would be as same as any other 26-year-old, even with a normal AMH or a high AMH. The problem is that the chemotherapy patients are different. If you look at our breast cancer patients, if they're 30 years old when they get their chemotherapy, they come back when they're 34 or 35, let's say, for pregnancy, their pregnancy rates with IVF at 35 are as if they're 42. So I think the post-chemo patients tends to age the eggs, whereas the normal AMH doesn't really correlate in someone who's not gotten chemotherapy with egg quality.
Right, and I think there have been studies kind of both ways, right, that have suggested that there's not a concern and that there is a concern. So to your point, which population is that? How far out do they need to be? Does that play a role in it? We try not to freeze eggs before 12 months, right? But some patients go for 6 months, right? And so I think when we put all that data together, what that looks like. Yeah.
Yeah, I agree. AMH doesn't correlate to pregnancy outcome.
Right.
But I think the
Across the
chemotherapy,
board.
the post-chemo patients, that definitely
different.
has a negative impact. Not just AMH is low for an unknown reason, just diminished egg reserve.
So I think for us, I mean, everyone on here who knows me knows that I'm going to go for gold at all times. So I think for us, we will send patients to have ovarian stimulation and have that discussion at least to offer them that opportunity with our REI colleagues as soon as they're pubertal. If in our discussion with them, they seem willing and they feel mature enough to undergo that process, because we go through that counseling about what that process will be. And so they have an idea. So that's our practice, and we likely will continue that. And that will allow us to capture more data. I don't know, Maria, did this change your idea on how you want to approach these patients?
So right now we're primarily actually offering ovarian tissue cryopreservation. Just because
what is your counseling in terms of what you're going to do with the tissue?
So that's really interesting. So when we have patients with hematologic malignancies, we basically tell them that we check the tissue for malignant cells, but we can't for sure say that there's ever no malignant cells in the piece that we're going to put in, because that's not the piece that we looked at under the microscope. And so that, we're going to pray and hope that our technology gets better, and that when they're ready to pursue parenthood in 10, 15 years, that perhaps we'll have the technology to do that. I know that we have it, but it's kind of in its infancy right now. And I don't think that there have been any live births in Canada as a result of in vitro oocyte maturation. So we do kind of disclose that this is like a hope, And we're preserving this ovary in hopes that we'll have that more advanced technology. When they're patients who it's not a hematologic malignancy, or it's not a high risk malignancy to be in the ovary, then we tell them that we would reimplant a piece of that ovary into, usually the contralateral ovary or a peritoneal pocket eventually when they're ready to pursue childbearing.
What about your Turner patients? Because you're taking ovaries out in Turner patients, yes?
I actually don't know. I've only been here for about a month and a half, and I've done 2 cases, and both of mine were for oncologic cases. I saw that Dr. Allen, one of my attendings, was here. I don't know if she can comment on if we've done any Turner's kids yet, because it would be very different based on
it would
the
be
quality
different.
of the ovarian tissue.
Right, we would all agree with you that a patient who's at high risk of ovarian failure would be counseled on ovarian tissue cryopreservation with or without a hematologic malignancy. And, the thought is that patients with hematologic malignancies may warrant 1 or 2 cycles of chemotherapy, and that might minimize the risk of containment in those malignant cells. We don't know that 100%, right? And
Right, yeah.
Mero's group is the one that's done a lot of this and has transplanted tissue back after doing some biomarker testing and doing some immunoassay testing, and patients have been fine thus far, right? But how many patients do you need to transplant it in to really know
Right.
if it's going to be fine? But I think we have to be really careful with the Turner patients that if we're removing an ovary, we're letting them know that there are great limitations to transplanting it back and with the IVM. And so if they're pubertal, I would encourage oocytes. Lisa, are you able to talk?
Just want to mention, Leslie, one more thing. The hematologic malignancies, what the Israelis are doing is they're transplanting a piece of the tissue into a immunodeficient mouse model also. So hoping and praying, these patients do not want to get their cancer back. So you really want to do everything you can to ensure that a transplanted piece of tissue is not going to have any malignant cells remaining viable.
So when you're counseling these patients, do you, if they're maybe reluctant to undergo a stimulation cycle, are you giving them the option of one versus the other, or are you kind of guiding them towards the preservation that you think is more clinically appropriate for them?
Sure, we always give both options, right? We say that success rates are the standard of care in Turner syndrome and Turner mosaics is oocyte cryopreservation. So we'll also always encourage that. But for patients who don't want to do that, yes, we'll offer ovarian tissue cryopreservation under an IRB protocol at the NIH. Our institution would not allow us to perform oophorectomies on patients with Turner syndrome because it is investigational, and we would need to provide the funds for that. So they do not allow us to put investigational procedures through insurance, and the patients cannot pay self-pay. So we could do this here, but we need to cover the entire cost for patients. And so we send them to the NIH because they have that option. And most patients that I've had conversations with would prefer to freeze eggs if possible. But again, sometimes the patients are just too young. Let me answer this question. For those who do kids with Turners, are you doing any in Turner mosaic patients with Y material or only XO? So we have sent several patients, we have performed oophorectomy in patients with Y material because it's a gonadectomy, and that is covered by insurance because it's coming out anyway because of the risk of malignant transformation to gonadoblastoma or dysgerminoma. So we're removing that so there's no cost to the patient. And then we have our pathologist take a look at the tissue. And if there are germ cells present, then we will freeze that tissue for the patient. We will send it to Pittsburgh to be frozen. If there are no germ cells present, or if there's signs of malignancy, then we do not freeze it. So they will go through certain sections, and we'll look with them, with the pathologist, and we'll look for tissue, and we'll send it. They always keep a portion of the tissue for a better histopathologic evaluation. And if a week later they find pre-malignant cells, then we will have the tissue come back from Pittsburgh. But we do offer patients with Y chromosomal material the option for us to evaluate the tissue. And if there are germ cells elements present, then we'll freeze it for them.
But Leslie, you would not transplant that tissue back into people. Obviously, the risk of malignant transformation is something, this is only for
That
that potential
persists.
in vitro maturation.
Yes, we do. Thank you for that. We do counsel them that in vitro maturation would be the option because we're taking it out. We're not going to put it back in. So again, limitation upon limitation upon limitation in that population.
And I don't know if you saw in the chat, Dr. Allen did say that we haven't done any OTC on Turner's kids either because it's research
It's
based.
research based. Yeah. So okay. All right. Does anybody else want to comment or ask any questions? I will always put a plug in for the database that we're building. So there's a national initiative called Reproductive Hope, so reproductive health outcomes and experiences. It is a collaboration between the Oncofertility Consortium and the University of Chicago's Data for the Common Good. So the University of Chicago has this international database of cancer, patients with cancer, pediatric and adult, and it allows them to bring data from, several institutions, 20, 30, 40 institutions, to bring their data into one area. So we have partnered with them to begin to collect fertility data and outcomes data in terms of reproductive health. So this is an example where pooling our data is going to allow us to make some statements sooner than later about the fidelity of what we're doing. And so right now we have a group of about 14 or 15 institutions. And as we finalize the database and allow institutions to contribute, we will certainly share this information broadly so that institutions can say, yes, I want to contribute my patient population to the database, or even be able to pull data out and request the opportunity to do research. And I'm so sorry for this. I'm at a luncheon because Maria Shriver is going to be here, so I had to be here. So I apologize for the noise, but yeah, so that we will be sure to share this information with individuals when we have this so that we can do big data work.
Hey, I have a question, Leslie. How standardized is stimulation for those youngest and prepubertal patients? What is stimulation like? And I'm sorry if this was covered.
I will let our REI colleagues here discuss it, but there has been a conversation regarding whether or not they require higher doses of gonadotropins. And in some situations they have, the younger they are, but it hasn't been statistically significant. And in many of the studies, they've shown that the use of gonadotropins doesn't vary and that the number of oocytes retrieved are similar for the younger population versus the older adolescent population. So there doesn't seem to be a difference. The concern is more discomfort, risk of ovarian hyperstimulation syndrome, how well they can tolerate it. That's been more of the conversation, but I'll let our REI colleagues weigh in.
At least for us in Colorado, we haven't done any prepubertal stimulation, but for our the few adolescents that we have stimulated, it's going to just depend on their ovarian reserve testing. The stimulation protocol that we do, it's going to be usually a GnRH antagonist protocol, and the dosing depends on their AMH and their AFC. But I will say the couple that I have seen here, we tend to kind of start on the lower end and kind of be more like judicious and kind of go lower and slower because we're not entirely sure how these patients are going to respond. But if they're 17, then we might treat them a little bit more as an adult patient and give them kind of like standard doses. But for the younger ones, I think we would tend to start lower.
I agree from Duke. Oh, sorry. We do the same thing, particularly because we're kind of always thinking, especially for the younger patients, that they very well might need an Ovidril or HCG trigger rather than using a Leuprolide trigger. And so we tend to, I think, start a little lower for the really young ones, just so that we don't get ourselves into a position where they've had this great over response, but then we are worried that they might not respond to a Lupron trigger.
Yeah, and I think also it depends on, so BMI, we use a bunch of factors, but it's sort of like a car. And I tell the fellows this all the time with the analogy. Some cars require a little more gas to get them going and some require less. And everyone's an individual and you sort of have to guesstimate it first. For those that have one shot, I mean, they're going to get chemotherapy in 2 weeks and you get one shot of doing this. We tend to be a little bit more aggressive, not aggressive, I hate that term, but a little bit more liberal in terms of the dosing for those that have more time. Again, we'll start out slower to try and avoid risks of complications like OHSS and other risks. And if we undershoot the mark, we have another shot next time. We'll just change the dose the next time.
Thank all of you.
Yes, thank you all for joining. It was a great conversation. If there are any fellows out there, REI or PAG, who would be interested in doing the next journal club and presenting it in the next quarter, then we will certainly love to have you. Otherwise, I will continue on rotation and pick the people that at the institutions that I know want to be involved. Feel free to always email any questions to our email. We have fertility consult. What is it? Fertility preservation at cuanschutz.edu. If you have any questions, or I think most individuals on here are part of the Oncofertility Consortium in some way. And we have 12 committees within the consortium, a pediatric adolescent committee. We have the female committee, male committee. So they have committee leads who can also help you with your questions. There's also a fabulous resource, which I will send to everyone on this email. It is our European colleagues have a panel, and they discuss complex cases across the world. So you would submit the patient information, and then they would convene in a rapid fashion, because these are urgent, especially in these cancer patients, and give you a recommendation that you can then, it's a written recommendation. You can take it to your colleagues and say, this is what the experts are saying we should do. And then they only ask that you then give them feedback regarding what you ended up doing, so they can know how that advice is taken. And I'm on that board. So if anyone's interested in sending a patient case, just let me know. We can help facilitate that as well, because we want to rise all boats, right? So thank you, everybody.
Thank you. Nice meeting you all.
Thanks. Great job.
Great job, Maria.